Good evening, everyone. Welcome to our webinar on treatments for lower leg and feet injuries. My name is Louise and I'll be your host this evening. Our expert presenter is Sports Medicine Podiatrist, Mr. Liam Stapleton. This presentation will be followed by a Q&A session. If you'd like to ask a question during or after the presentation, please do so by using the Q&A icon at the bottom of your screen. This can be done with or without giving your name. But please note this session is being recorded, so if you do provide your name, that will be in the recording. If you'd like to book your consultation, we'll provide contact details at the end of this session. And I'll now hand over to Mr. Liam Stapleton, and you'll hear from me again shortly. Over to you, Liam.
Thank you. Thank you, Benenden Hospital, for giving me the opportunity to speak to you all today. Please ask any questions you've got, and I'll do my best to answer all of them. As said, I'm Liam Stapleton. I'm a specialist in podiatric sports medicine here at Benenden Hospital. A few things. I am the vice chair of our special advisory group to the Royal College of Podiatry. My fellowship from the Faculty of Podiatric Medicine from the Royal College of Physicians and Surgeons in Glasgow. I have postgraduate qualifications in podiatric sports medicine and podiatric surgery. I got back to do some guest lecturing from my university, Queen Mary University, London. I have an interest in scanning and injection therapies. We're going to talk about a few a kind of broad range of problems today, hopefully touch on things that might mean something to some of you at home. We'll talk a little bit about the foot and how it's the structure of it and how it's made up. Talk about some common injuries and some sports injuries and how we might treat some of those problems, some ankle problems and some ankle treatments, and then talk about my surgical colleagues and how they might also better help. And then I'll hopefully, in about half an hour or so, we'll be answering all your questions. So please ping them through. That might well be the most interesting part of the whole presentation. So the foot, broadly speaking, most people has about 26 bones, not including the accessory ossicles and sesamoids. Also, you have muscles and tendons, ligaments in your feet alongside the bones and joints. Help to support your whole body when you're walking and running and jumping. Injuries can be caused by several different factors. Obviously, trauma being one, and then regular repetitive stress is obviously one of the other most common reasons someone might get injured. So the hindfoot or the rear foot predominantly has the two bones, the talus and the calcaneum, the ankle bone and your heel bone, and obviously that articulates with the bottom of your leg or your ankle. This part of your foot is responsible for the first initial contact, heel strike when you walk, and its responsibility to adapt to the terrain you're walking or running on, and absorbing shock. The fractures in the heel are relatively uncommon, but can be caused by extreme force, and a calcaneal fracture is often called a lover's fracture, as it's commonly seen when the lover jumps out of the window when the husband comes home. Then obviously the other side, going on the point from the previous slide, recently I saw a good lady who had some osteoporosis, and she had a stress fracture from running in her heel bones, and that's obviously always a possibility as well. Your midfoot, this is predominantly the middle or the arch portion of your foot, made up of your navicular, your cuboid, and your three cuneiform bones. These are little square bones inside your foot. The joint where your rear foot and your midfoot connect, it's called the Chopart joint. It's made up of 4 different bones. It's an unusual type of joint made of more than just 2 bones. Made up of the calcaneal cuboid, so the joint between the calcaneus and the cuboid, and the talonavicular, or the talus and navicular bones. Forefoot is mainly your toes and your metatarsals. And this joins your midfoot at the Lisfranc joint, which is also called the tarsal metatarsal joint. Again, another joint in the foot that's made up of lots of different bones. So the 5 metatarsals, 3 cuneiforms, and your cuboid. So obviously different strains and sprains of foot injury is and how these are separated into different categories. So we obviously can get a mild strain or sprain, and this can be graded both on symptoms and also radiologically, and broadly speaking, they follow the same 3-step pattern. So very slight damage. This is normally impossible to see under an ultrasound or an MRI, and generally resolves very quickly. So mild tenderness, minimal swelling. Sometimes you get some laxity, the ligaments, they stretch a bit more than they did before. Normally probably resolves itself within a week or two. A grade 2 strain or sprain, this is where it becomes a little bit more moderate. So we're getting little tears of the fibers, and this can stretch from anything from slight tears to very slight tears to something that's a bit more visible on a scan, and these can be picked up. And there's probably something to do with between a 2-week and a 6-week recovery. And then obviously you've got your really severe strains and sprains, and this is where you've got significant tears and rupture. And obviously this is where surgical correction with my surgical colleagues would potentially come in. So if you had a rupture that wasn't healing by itself, then there are procedures that can be done to help with that, speed up that process. And we're looking at probably a 6 to 12-week recovery for someone with anything severe. With common foot conditions, we're going to talk about quite a few of these as we're moving forward today. And these are probably some of the things we see most commonly, or I see most commonly in kind of sports medicine of the foot and ankle. Hallux limitus, Hallux rigidus, this is stiffening of the big toe joint, very often as a result of arthritis. Mortons neuroma, which is a trapped nerve essentially in the forefoot, gives you burning sensations to the forefoot. Sometimes neuromas and capsulitis, the next thing on this list, are together. And I saw one of these ladies, I saw a lady today with both of these things. Capsulitis is where the joint that connects your metatarsals to your toes becomes swollen and inflamed. The capsulitis can often become a plantar plate tear or plantar plate rupture if they're left over time. So this is kind of, it does progress onto that. Hallux valgus, this is where you get, this is a proper name for a bunion. Ingrown toenail, something we see a lot of, and this is a minor procedure we do in outpatients. It takes about 3 or 4 minutes to cure you of an ingrown toenail, and that's obviously something well worth seeing, and is a common problem in different age groups. Arthritis. So arthritis in any of the joints of the feet is seen. Arthritis can be both wear and tear and inflammatory. And so the different types of arthritis and they have different telltale signs and might well affect different joints. A ligament injury, so there are lots of ligaments in the foot and ankle. Obviously, most people are commonly aware of an ankle ligament injury. You twist your ankle, but there are other ligaments too. And the next one, plantar fasciitis, is a type of ligament that's really commonly injured. And obviously can cause quite significant ongoing discomfort. Something I see quite a lot of is an adult acquired flat foot. It's not to be confused with flat feet in general, but someone who didn't always have a flat foot and the foot becomes flat, and that becomes a pathological process in its own right. There are different reasons for that. We'll talk about that in a bit, and the main causes for it. And then obviously one of my, again, most common things I see in clinic is Achilles tendon problems. There are lots of varieties or subcategories of Achilles tendon problem, and we'll talk about some of the most common ones later on and how we might go about treating some of those. So arthritis. So we see a lot of this in rear foot and midfoot, so the ankle and subtalar joints, midfoot, the arch joint, and a combination of all, which is quite common. We think that about 60% of the arthritis in these joints is caused by historic trauma. Now, that's not necessarily last week you twisted your ankle, but often trauma 10 or 15 years ago, and that can be, and it was always thought for a long time that road traffic accidents accounted for a really high percentage. We think that the safety features in cars now make that less so, but it's still a very popular thing, and certainly one of the most common problems I see in clinic. Within the hypermobility, so joints that move more than they should, also contributes to making up most of the other 40% reasons for this. And you see a lot of overlap between the injury, trauma, and the hypermobility, and that's a bit of a recipe for an arthritic midfoot. All right. Generally, like any arthritis, we're looking at pain, stiffness. It tends to be more sore and stiff after periods of rest. Can be caused by, obviously made worse by activity. Often whilst you're moving, for people when they're not too badly, not too severely afflicted, when they're moving, they're mostly okay. Obviously can cause pain at night, and that's where you start to get bone marrow edema in those joints as the cartilage starts to wear away. So you might call that bone on bone, as your GP might call it. Midfoot arthritis. Now, this is probably the most common thing. I've seen this at least 3 times today in my clinic today. Normally affecting the metatarsal joints. This is the joints between your cuneiforms and your metatarsals. And this tends to cause some flattening of the foot, real difficulty in towing off, pushing off when you're walking. So as your body weight moves over your foot, it makes it really difficult. People limp a lot with this problem. This should be very treatable. It's very common and probably massively underdiagnosed. So I see this, it's often misdiagnosed as tendinitis. I joke with people when I see them sometimes that it's almost never tendinitis in the top of the foot. And this is by far and away more common. Easily diagnosed in clinic. We see the telltale signs on ultrasound scan, and should be very treatable. Protocol for it is pretty proven, and I normally say that the patients I see, only maybe 1 or 2 a year get referred for surgery, so most people make a near full recovery. And I normally consider it to be management of that arthritis rather than cure. The surgery is also very successful for this, but rather involved, and most of the surgeons I work with here prefer we do the conservative stuff first before they get the screws and plates out, because if they don't have to do the surgery, then obviously that's a better way to go. We tend to find that the same pattern of pain, stiffness, swelling that you see commonly with arthritis. You notice that there's bony growth on the top of the foot, so it becomes bumpy on the top and certainly painful to the top. That makes footwear fitting difficult because it tends to compress the tendons and the blood vessels and the nerves onto those bony prominences. Can give you some strange sensations too, and predominantly because of these nerves running across the very surface of these bones. There's not a lot of extra padding to protect them from the spiky bits of bone that grow underneath them, and that's why it's often misdiagnosed, because the symptoms are thought to be that of the nerve or that of the tendon, but really that's secondary. If we didn't have midfoot arthritis, the tendons and the nerves wouldn't be impinged, and you wouldn't have those sensations at all. We see a lot of this sort of problem in clinic, and sometimes symptomatic and sometimes not. So toe deformities, claw toes, hammer toes, and mallet toes. And basically these just describe different types of a deformity to the lesser toes. You can get a hammered big toe. It is rarer, but you see a lot of second, third, fourth. Obviously the difficulty with these is that they can rub on shoes, make footwear difficult fitting, and can ulcerate certainly in the diabetic population, and that's obviously something we want to avoid. These can be caused by different reasons, so we know that someone with a high arched foot is more prone to this sort of problem, but I would often see these clawing of the toes once the plantar plate has ruptured. So years ago, that was something that wasn't particularly well known because imaging wasn't there for us to be able to see it, and now we have a better idea of what's going on, causing some of the toes to go like this. Plantar plate tears or ruptures, toe subluxes or dislocates, and you tend to get the clawing that goes with it. Often there are different ways of treating this, conservative and surgical, and probably kind of seeing how badly affected it is and having an assessment is probably the best way to go to inform that. And obviously, this leads nicely on to the next slide here, where we're looking at forefoot pain. So this is, you see the diagram there, and we're looking at a tear to the plantar plate. I don't know if you can see my cursor, but the plantar plate's just down here. And this is a ligament that holds your toe straight, essentially. Once that starts to tear, the toe starts to curl up and starts to retract. And this is, it's commonly caused by too much load on that joint. So there are reasons why you can have that. Long metatarsals, so your long metatarsal compared to the ones around it, that can cause it. You have a stiff big toe or hallux valgus or bunion, that can cause it too. And the wear and tear on the plantar plate causes it eventually to begin to tear. And we think of this as a spectrum between capsulitis, the capsule gets inflamed, and then you get plantar plate tears, and then obviously the rupture, and then you end up with this stiff, retracted, clawed toe. Mortons neuromas, this is the other most common reason we get forefoot pain that I see. Certainly lesser toe forefoot pain, and I probably must have seen at least 3 people with Mortons neuroma at least today as well. It's one of the other most common things I see. And you often get an overlap between the capsulitis or the plantar plate tears and the Mortons neuroma, so sometimes they can be confused easily. The Mortons neuroma essentially is a trapped nerve in the forefoot, tends to give you nerve symptoms, so numbness, pins and needles, burning, shooting pains, normally from the ball of your foot into the toes. Normally made worse wearing footwear. So for normally, the way to relieve it for most people would be take the shoe off. The nerve tends to thicken up with scar tissue, which then causes it to take up more space, be trapped between the bones even more, so it makes the symptoms worse. And that's something that we know is, if you catch it early enough, is very treatable in outpatients, and as a conservative treatment. We know that as long as the neuroma is less than 5 millimeters in diameter, and that, put that into context, is 5 times the size it should be, then you've got a really good chance of responding to a course of conservative treatment, and about 85%, I would say, in my clinic. And then about the final 15% is a surgical intervention. If you wait till that thickening is beyond 5 millimeters, the chances are that's a surgical intervention. And very often at that point is we'd talk about sending you straight for a surgical opinion for a decompression, because it's probably beyond what we can manage conservatively. But that is more than 5 times the size it should be. So that's, get these things checked out sooner, probably is the moral of that story. So we know that the gap between the 3rd and 4th toes is the most common, but we see a lot of it in the 2nd and 3rd as well. Very rarely do we ever see between the big toe and the 2nd and the 5th toe and the 4th. That's a much rarer, and it may be a once a year, once every 2 years, we might see that in a patient. So there are different risk factors. Shoes and the types of shoes you wear are a big risk factor. We know that narrow shoes and any shoe or foot type that puts a lot of weight on the ball of the foot is provocative. There is a common gait pattern I see with almost everyone who has a neuroma, with this, I call it an abductory twist, so which when you stand and your foot twists and flick your foot out. Almost everyone I've seen with a Mortons neuroma, and I've done a gait analysis on, they all walk the same. And I believe that this, coupled with that gait pattern, is probably what causes the thickening of the nerve. The patients often describe these electric shock pains, neurological symptoms. The walking on a pebble is something you would read on almost every website about Mortons neuroma, and is probably a little bit of a fallacy. Most of them don't feel like walking on a pebble. but that's normally how capsulitis feels. But that would be, when you read up about a Mortons neuroma, that tends to be one of the things that's said. And because there's such an overlap between these symptoms, that is something we would often think of being a swollen capsule rather than the nerve. How are we doing on time? Okay. Being slow. Sorry. So quickly, I mean, certainly my protocol for Mortons neuroma, we do injection, guided injection under ultrasound. That we know if it's for less than 5 millimeters, that's got a 50% chance of working. We know that's 75% based on 2 injections. So that means for 75% of people with two injections will get complete symptom relief. And biomechanics plays a part, and putting an insole in also helps to bring that up a bit higher. And more importantly, prevents recurrence. In my experience, we know that surgery is also an important tool in this. Hallux rigidus. So this is something we see very commonly. Hallux rigidus, arthritis of the big toe, put in context, is the most common incidental finding on plain film x-rays. All right, people have x-rays for any reason on their foot. This is the most common finding. The majority of people don't have symptoms. So that puts it into some context. Most people can live with some stiffening of their big toe. How bad that is and how inflamed that is normally denotes whether or not you need treatment. People come in because of pain in their big toe. I estimate maybe only 5 or 10% of people with Hallux rigidus end up presenting to clinic for the Hallux rigidus. You tend to have this knock-on overload of the lesser metatarsals with the problems we've just seen as a result, so secondary to this. So it might not be this doesn't hurt, but you end up using other parts of your foot more, which puts more of a strain on them. And so this might be the underlying cause, but causes something else. And essentially what this is, in lay terms, is the joint becomes a bit arthritic and you can't bend the big toe anymore. People will always bend it down, and they'll show you in clinic they can bend the toe down. Unless you climb trees, you don't need to bend your toe down. So how much it bends up is more important. And the test would be to bend your toe up. And if it doesn't bend, you probably tick the box. Hallux valgus. Now this is known as bunions to almost everybody. And this essentially is a deformity that is progressive, so it tends to get worse. Tends to cause pain on the eminence, so the lump, but also tends to cause a lot of knock-on effects with the rest of the foot. Dislocation of the lesser toes, overload of the lesser metatarsals, other parts of your foot having to work harder because your big toe doesn't point straight anymore. This is a surgical problem. You can't make Hallux valgus straight again, no matter what you do to it, unless you have pins and screws. And this is what my surgical colleagues do every day. They probably have a list of these every single day of their working life, and probably take them 20 minutes to fix. Really are that skilled at it. If it's not hurting, we wouldn't always necessarily say you need to have it done. If it is hurting, then also there's a reason to treat. The braces and toe straighteners that you see online, you see on social media, they don't work. We know that the studies have been done, and the potential correction they offer was less than the error in reading the angle. So it's so small that when you read the angle, that was less sure than the width of the line that they read the angle with. And so pads, if it hurts to rub on shoes, straighteners, you can see on the right hand side, save your money. So Hallux limbus, we mentioned this already, Hallux valgus. And then the final part of this that affects your big toe, you have 2 little pea-sized bones underneath your big toe. They're called sesamoids. And these all commonly become injured. And this is a very common sports injury. You see a lot in football players, anyone who has a stud under that part of the foot, and dancers, the other group we see a lot of this in. It can get inflamed. You can get stress fractures to them, and in severe cases, and maybe a couple of times a year, we see this where you lose the circulation to the bone, and often that's where stress fracture has not been treated, and then you end up having the cut off some of the circulation of the bone. An unacquired flat foot. So this is someone who hasn't always had a flat foot, but the foot has become flat. So often there's a big asymmetry between left and right. The foot, there is a spectrum to this. So this is commonly caused by weakening of one of the main structures that holds the arch up in your foot. Most commonly, tibialis posterior tendon, the spring ligament, plantar fascia, also somewhat involved. So you start normally, there's a spectrum with this. It starts with some pain up inside of your ankle bone where the tendon is inflamed. Then the second stage of this is where the tendon stops hurting because your brain stops pulling on it. So it switches that off and the foot flattens. And then third stage, that flat foot becomes arthritic. And then the fourth stage is where the arthritis becomes bad enough that you can't really use the foot anymore. And you want to come in when you're stage 1. I normally say, finding stage 1, come in stage 2, stage 4, and we're limited, really limited. And it might well be that's a surgical fix. So treatments wise that we offer here, so certainly in my, with myself, obviously consultations, diagnosis, image guided injections and ultrasound scanning. So we have a scanner with me in clinic all the time. We do some nail surgeries, there's ingrown tower nails that, like I say, we can fix that in 3 or 4 or 5 minutes, completely pain-free. Do some shockwave therapy, and this is really good for certain Achilles problems and plantar fascia problems. Custom insoles, a couple of custom orthoses, and we make the latest 3D printed custom orthoses. And kind of anyone who's had orthosis before and can't fit them in shoes, that's probably the answer. The 3D printed ones, we can fit an insole into a 6-inch stiletto if you wanted me to. They really are. We have so much more range that we can make insoles for now. Gait analysis, that's an important part of any podiatrist job. Looking at how you move, looking at how you walk, spotting weaknesses, asymmetries, and obviously then physiotherapy and surgical opinion leading into and playing a part of that multidisciplinary team. Physiotherapy is really good for exercise rehabilitation. We spend a lot of time sending our patients with physio, and then obviously the surgery. So many patients who aren't getting better with a conservative treatment, well, often say to them, have a chat with the surgeon, find out what's involved, and we can come back, carry on with the conservative stuff if we need to, but at least you're informed and can make educated, informed decisions. We have ultrasound clinic, as I said, MRI, and X-rays, right, that can be done here on site. So shockwave therapy is a type of treatment that stimulates your body to repair itself and is commonly seen as an alternative to corticosteroid injections. And really good, like I say, for plantar fascia and Achilles problems. We think kind of meta-analysis, the analysis shows that about 80% of Achilles problems resolve within 3 sessions or so of shockwave therapy, and something like 75 to 80% of plantar fascia problems. So certainly they're the 2 most common things I would use it on, that are best indicated from the evidence base, the studies that have been done. Gait analysis, let's skip that because we're running out of time. I'm going to get told off. Injections, a whole range of different injections, from local anesthetics for doing simple nail ops, pain-free. Corticosteroid injections, very good for certain problems. We do a lot of them for in combination with the sodium hyaluronate below. That is basically like a lubricant for a bit like WD-40 for rusty joints. All right, combination of the 2 works really, really well for some arthritic joints. High volume Achilles injections is one we do where we use that as a type of water injection that cures mid-portion Achilles tendinopathies. That's a really, really useful one. Again, with an 80–85% success, very high success rate. Insoles, where we've spoken a little bit about that, so let's flick beyond. Ankle problems, there's a whole range of different kind of rear foot and ankle problems that you can have. We spoke about some sprained ankles already. Achilles tendon problems, so that's probably one of the most common things I might see in clinic here. Bursitis, and there's an overlap between bursitis and Achilles tendinopathy. Broken ankles, I mean, we do pick them up unusually a lot, considering you'd imagine, especially people who've been x-rayed by A&E already, which is always reassuring. If you with ankle, if you've twisted your ankle, you've got an ankle trauma. If you can't take 3 steps, either of your ankle bones hurts when you press it, or the bony lump on the side of your midfoot. If any of those hurt, we image you. That's standard, okay? Or if you can't take 3 steps. So if you have twisted your ankle and you've already broken it, you've been told by any that you haven't, then that's kind of pretty standard approach. Come in and we get that x-rayed. Ankle arthritis. So obviously, we obviously the conservative treatments for this and surgical treatments. Obviously, it can be osteoarthritic. We spoke about that being primarily as a result of trauma. And you can get ankle impingements as well. And these are common both from bony overgrowth and from accessory ossicles. These are little floating bones that get caught. Saw a young girl this morning with one of those at the back of her ankle, which we injected this morning, we're hoping. Ex-ballet dancer, very common in ballet dancers, posterior ankle impingement that which she'll make a full recovery. So exercise is really important with ankle arthritis. Injections, really important as well. Something we use a lot of, both because we know it reduces pain, but when we combine them with the hyaluronic acid part, we know it slows down the worsening of the arthritis. So the arthritis, it slows down the degenerative process. And we know that slows it down by years. So it's a really powerful tool. Depending on where the arthritis is, insoles are a really important part as well, and some of that will depend on which joints are involved, and obviously your standard painkillers, and then obviously surgery. We saw the picture previously, a nice couple of screws through there, and obviously there are certain different procedures that can be done. People with ankle fusion, which is where those screws are, that's got a good, probably got the best outcomes, but they can do replacement too. Ankle injection. So a bit like I just said there, mix of steroid and hyaluronic acid is my approach. That normally gives you symptom relief for about a year, 9 months to a year. And I have quite a few patients that come back regularly to have that done and repeated on a yearly basis. My colleague here also, Mr. Dinser, who we did this presentation together with last time about 6 months ago, he tends to go with a more steroid approach and a slightly different way of approaching the same thing. Plantar fasciitis is again probably one of the most common things we see in clinic. Heel pain, the base of the heel tends to be very sore on first step and normally resolves within 10 or 15 minutes of getting up. Generally we speak gradual onset and it's somewhat overdiagnosed. Something that's simply diagnosed in clinic with an ultrasound scan. We can judge how bad it is. Plantar fasciitis is a broad term, and we might use a term called plantar fasciopathy. Plantar fasciitis is an inflamed plantar fascia, and that accounts for actually quite a small percentage of plantar fascia problems. Plantar fasciosis and plantar fibroma is also part of that, and then plus or minus calcific changes. So we judge those that categorize it, and then we can, that dictates, I think, what we think is going to work best. One of my favorite things to treat in clinic, that's a lovely picture here of a mid portion Achilles tendinopathy. If you can see my cursor, which I don't know if you can, but that's the mid portion of your Achilles there, and see that is a lot thicker than it should be. It should be about this thick. All right. Really common problem, and one of those problems that tends to rumble on for years. I see a lot of patients like this, been going for years. Had a guy flew in from Dubai at the beginning of the year, have one of these injections done for this ex-professional sportsman, and yeah, 8 weeks later he was completely back to playing sport again. Brilliant. Essentially we use a high volume of steroid and anesthetic, a high volume of water, anesthetic, and a touch of steroid, and it's called a hydrodissection injection. It mimics the surgery that you can have done for it without all the surgical risks. through an injection guided by ultrasound. That is certainly for this sort of problem has a 80-85% or more success. The rupture is always a possibility. It's very rare, but that is something we see kind of on a once a year basis. They're probably one too many. Exercise rehab, really important. It's kind of mainstay of both getting better and staying better, more importantly. So one of the things we always do is get you some rehab, and you complete it daily. Shockwave is another important part for this. Sometimes we shockwave more when they're down the insertional, when they attach to the bone. That tends to be, we do a lot more shockwave for that, but it also works well in this mid portion. And I would normally say try and avoid opposite. There's something that we sometimes see with GPs, sometimes older GPs, who inject right into the Achilles tendon. Where Achilles tendon injections, if it's not guided, don't risk having an injection in it. It's not an injection to be done unguided. You make sure the image guided, and ideally ultrasound guided. Otherwise, you don't know what you're putting it through. And obviously, one of the things we see a lot of is a combination of Achilles problems. This is with plantaris, the little tendon that runs alongside your Achilles, fasciitis, bone deformity, and obviously calcification at the insertion. So obviously part of scanning these is to work out how we categorize this, and it gives us an idea of what we think is going to work best. My orthopedic colleagues here, so we got the three of them, Mr. Southgate, Mrs. Insa, and Mr. Dunning, all consultant foot and ankle specialty surgeons. Obviously treat a whole range of foot and ankle problems surgically, and are real experts in their field. There's a whole range of different things that they would see and would regularly treat, and there's obviously a lot of overlap. And obviously, broadly speaking, their job is to pick up all the ones that don't respond to conservative treatment, and obviously have brilliant success rates doing so. Obviously, there are different types of surgery involved, and a lot of that is dependent on the surgeon. One of the things I say to a lot of people would be to have that consultation with the surgeon if conservative stuff has failed. Have a chat with the surgeon, find out what's involved, because obviously there's reading from a textbook and applying those principles to everyone is not how this works. They normally run some x-rays of you, see exactly what's going on, see the structure of your foot through x-rays. This is how surgeons see people. And with the bit like we always joke with you watch the Matrix and the guys are watching all those numbers flying up the screen and film the Matrix. The foot surgeons see people with x-ray eyes. And you're looking at here, there's a couple of Mr. Dinsa's pictures, I believe, and they're probably treating the same problem, midfoot arthritis, two different approaches depending on what works best for that person. That's us. Probably 8 minutes late. Sorry.
You're not late. That was really interesting.
I said a minute a slide.
You did. You covered so much. There's so much that is involved with the foot and ankle. So yeah, it's really interesting. Hopefully everyone else found it interesting too. We have some questions.
Brilliant.
Yeah, and I'll just go through them.
Yeah, far away.
This one says they've had people comment that they have flat feet or their feet lean inwards, but this has never caused them any issues, so they haven't seen a podiatrist as of yet. Should they book an appointment if it doesn't affect them, and could there be any long-term problems?
So look, we think that the short answer is probably no. So we think that certainly depending on ethnic origin, that it's normal for a lot of people to have flat feet. So we're looking at people from South Asia and of African origin, that flat feet would be the norm, and it would be unusual to have arched feet. Some of the focus on arch height is based on some work done in the 60s and 70s in California by some really early surgical podiatrists, who the three of them did cadaveric studies, so studies on dead people's feet, and all of those basic biomechanic principles that we see a lot of still run true today, or still are spoken about commonly today, about flat feet and arched feet, come from those studies, which were based on 10 individuals. And some of that normative data that's been probably banded around for a long time is based on 10 individuals. And that it probably isn't a good cross section of, you know, of the norm, I would say. If like, I've got a lovely photograph somewhere of Usain Bolt, who's got the flattest feet and was the fastest man who ever lived. All right, if they don't cause a problem, then they're probably fine. And if they've never caused a problem, they're probably fine. Part of what we'd do normally, if you were worried, would be to assess their function. How good are they functionally? Because just because it's flat doesn't mean it's not functionally very good. We know that people with flat feet are more likely to have certain problems. We also know that people who've got high arched feet are also prone to having certain problems. A whole different list of other problems, but they're equally as likely to have problems. And so it's not a given. Turn the lights off for me here. Let me just...
I'm not sure why that's happened.
Yeah. The nurses and outpatients are ready to get rid of me, aren't they? It's you know, the lights get switched off. It's here in the dark. We're like, definitely, we have enough of this talk now. Turn those lights off. Yeah, and so functionally, it's all about function for me. All right. If they function well, flat, then great. And if they don't function well, then might well start with something simple like some exercises to improve that function. It wouldn't necessarily mean it's a pathological problem in its own right.
Okay, thank you. This person says they've had ankle fusion due to injury and they're looking for help with gait and footwear. Is there something you can help with?
Yeah, so look, a couple of things that kind of simple stuff. We think certainly when you had ankle fusion, obviously you have some limited range of dorsiflexion. So your foot doesn't move up and down as well as it used to. And it normally doesn't get rid of all of that, but there's normally a fair portion is reduced. There's a bit of compensation at some of the other joints. So it depends on what type of ankle fusion you've had as to how bad that gets. We tend to feel like a rocker-soled shoe works best. Right? This does mean you have to be kind of a bit stronger through your core to stay upright, because obviously your core has to work a bit harder to stabilize yourself on a rocker sort of soled shoe. But that sort of shoe works really, really well. There's a brand of training shoe called a Hocker, which is one of the ones I recommend a lot of patients wear, or an MBT sole shoe. They work really well for people who've had ankle fusion or who have really severe ankle arthritis. They already have that. Severe ankle arthritis will give you the same, almost the same limited ankle movement as you would get with a fusion. There's not normally a great deal of difference between movement pre and post surgery when the ankle's bad enough. That sort of rocker sole shoe is probably one thing I would start with. We can't obviously probably more we could do specifically if you know, see your x-rays and see what kind of sort of surgeries you've had and how restricted you are assessing function, but the best way to help yourself is get the kind of that sort of rocker soled shoe.
Yeah, okay, thank you. This person has numbness in both feet attributed to arthritis. They believe this is irreversible, but are there any medical and surgical interventions that might help alleviate symptoms?
So probably it opens up more questions as to where she has arthritis.
Mm-hmm.
I'm guessing probably lower back if it's both feet. But maybe if she wants to come back on and let us know if that's like lumbar spine arthritis rather than foot and ankle arthritis. It's be rare to have bilateral numbness or nerve symptoms like equal on both sides if it wasn't from your back.
Okay. Is it possible to have ankle injections after recent knee surgery? Yeah,
so look, I would say it depends how recent it was. The surgeons often inject the joint after, depending on what type of knee surgery you've had. But if you're like a knee resurfacing surgery, they often inject into the joint they've just operated on. That's really commonly done. Normally, once your stitches are out, the wound's healed, that should be relatively safe to do.
Yeah, okay, thank you. This person has severe lower leg pain, apparently caused by the way they walk. They have fallen arches and now notice dents appearing in the legs.
Okay, that's interesting.
Yeah.
So it sounds like maybe more than one thing going on there. So, but presumably the dents are from swelling, presume, and the kind of edema you get, perhaps. Look, so obviously when we spoke about, we had flicked across the flat foot problem really, really quickly. It's very, very involved. So the main tendon and muscle that's responsible for holding the arch up in your foot is in your leg. So when that starts to, when the arch starts to fall, it's normally because that tendon is either being overworked or is torn or is tendinopathic. There's a whole range of different things that go on with that. That will give you pain both in your leg, your ankle, and potentially your foot as well. Once the arch falls, once it starts to collapse, you become apropulsive. And so your foot struggles to push you forward when you walk, which puts a lot more strain on your Achilles and your calf muscles, the main calf muscle, your gastroc and soleus, the ones responsible for pushing you forward when you walk. So that puts a lot more strain on those two. So there's obviously reasons why that would happen with that pattern. Probably that would be one, you have to be assessed for that. I think we'd have to have a look at you and actually see what's going on, see what stage you're at, what the underlying causes were, and obviously tackle each of them in order.
That sounds sensible. Okay. This person asks, should they be worried about thickening the skin on the outside of the big toes is not hurting presently?
So normally when you get thickening skin, it's normally a sign that that part of your foot is bearing more pressure or more weight than another part. So there are different reasons why someone might get an increased skin on the outside. So Hallux limitus will do that to you. So if your big toe doesn't bend up like it should do, you tend to roll off that side knuckle of your big toe. And so like this, rather than toeing off straight, you tend to come off the side. And that would be one of the reasons why you get that. If you have the Hallux valgus deviation, so the bung-in deviation where the big toe deviates inward, again, that's already pointing in, so it becomes very difficult for you to toe off the end of your toe because it no longer points straight, it's pointing over there somewhere. So you tend to roll off that inside knuckle too. So there are two reasons why that might be the case. It might well be that it might not, the hard skin in of itself might not be a problem, but it might be suggestive of something going on under the surface, perhaps. One of these things we know that a lot of people have, Hallux limitus or Hallux rigidus, arthritis in the big toe joint. If it doesn't hurt, we don't always do a great deal to it. I wouldn't necessarily think we always do something to it. It's very common. And most people, if we live long enough, will probably end up with it. One of your feet at least. So it wouldn't always, and for most people, that's not painful. So it wouldn't always do something to it. But if she's worried about it, probably worth having looked at.
Yeah, that sounds sensible. Okay, this person has had multiple stress back fractures in both feet the last 2 years and now has pain in both feet and finds walking extremely painful. Could you help?
Yeah, well, presumably she's been screened by rheumatology for osteoporosis. That would be kind of first thing. If you had more than one stress fracture in a short period of time, then yeah, definitely screen with, I'd send you rheumatological colleagues to make sure that you had your bone density assessed and relevant medication given to strengthen the bones back up if that's a possibility. Yeah, then obviously looking at which bones were the stress fractures were in, and looking at how we might, reasons why that might be. So we think of, say, one of the most common second metatarsal stress fracture, normally because of bending force that's doing too much work. That would be a type of insole and shoe would resolve that problem in a similar way that a midfoot bone stress fracture would be caused by compression. This is on the top of the arch. If there's compression there, that can cause stress fractures on that too. And again, that might be a different type of insert that we might look to offload that with. We just try and look at the bone, see if we work out what the contributing reasons are for that, and then tackle those reasons. Obviously, bone health would be, if it's multiple stress fractures, bone health is a big question mark there, and that would be something we definitely want Dr. Sahar or Dr. Paul to have a look at with regards to bone density testing, I think.
Yeah. Thank you.
We can help with the pain. So yeah, with regards to the question, yes, there are lots of things we can do for that, and probably that my colleagues as well as a multidisciplinary approach would be able to help with too.
Just going to cover off a couple more questions now.
Absolutely.
So this person says the car door blew back on their foot a year ago and the foot swells every time they walk on it, and below the little toe and the 2 adjoining toes. What could be wrong? Sometimes they get numbness too at night.
A couple of things there really. Fractures, perhaps stress fractures, that's obviously a possibility. So if it's hurting, getting worse as she walks, that's a possibility, and that would give you numbness across that region. Mortons neuroma, that would obviously be a possibility too. So if you've got swelling of the nerve that's there, arthritis, so post-traumatic arthritis, that's a possibility too. Probably, yeah. But look, not all of those things, probably most of those things we're going to see with an ultrasound scanning clinic. So that might be the first point of call. Have it assessed, have it looked at, and then obviously, once you've got diagnosed, the treatment's easy. The treatment bit follows itself once you know what we're treating.
Yeah, cool. Okay. After steroid injections, how long is recovery, and when could this person get back to cycling?
So it depends what you've injected, I guess. And I mean, broadly speaking, my broad protocol, and I probably follow whoever's injected you, would be follow their protocol rather than mine, because I don't know what they've injected, how much they've injected, what they've injected, and what sort of condition. So, but my protocol is normally no running and jumping for about 7 to 10 days after injections, and then a graduated return. And so normally I'm happy for cycling. That you said, is it run cycling? You said, yeah. So yeah. So look, I mean, cycling should be fairly straightforward for most of them, I would say. But that obviously I'd follow whoever injected you. It's their advice is king, because obviously I don't even know which bit of the youth they've injected. But yeah, my protocol is broadly 7 to 10 days.
Okay, and our final question. This person has some resting pains towards the back of their foot and ankle after exercise, particularly running. Is it reasonably common, or should they see a podiatrist?
Yeah, so there are different reasons why you might get pain at the back of the ankle. Obviously, Achilles problems, that would often gives you pain for 24 to 48 hours after exertion. Obviously very common in runners. That's obviously one possibility. Posterior ankle impingement is another one. So again, that would be where you're getting some pinching of the back of the joint capsule, sometimes of the tendon that runs through there, the big toe tendon that runs through there, or extra little bone that's there. That pinching of that through that region, that would also give you a similar pattern of pain. Often these kind of inflammatory pains don't hurt when you're actually running, but would often hurt after you've been after you've got cold, so once you stopped and rested. Yeah, probably I would. Yeah, certainly if any aches and pains, I definitely recommend seeing someone who deals with that part of your body. That would be kind of simple, I think, the simple answer. So yeah, come in and see us and I'll look at
it. Great, thank you. Yeah, that's all of our questions. If I have with Mr. Nee, then we can get back to you if you've provided your name. If you would like to discuss or book a consultation, our private patients team is available between 8 AM and 6 PM Monday to Friday. You'll see on the screen we're offering a discount for joining the session. This is applicable for the next 7 days with the terms on the screen. At the end of this, you'll receive a short survey. We'd really appreciate if you could spare a few minutes to feedback, because it really helps improve our future webinars. Our next events are on hip and then on knee surgery separately. We're also doing a webinar on enlarged prostate treatment and one on varicose vein treatment. You can visit our website to sign up to those. So on behalf of myself, Mr. Liam Stapleton and our expert team at Benenden Hospital, I'd like to say thank you for joining us today, and we hope to hear from you very soon. And have a nice evening and goodbye.
Many thanks, everyone.
Thank you.
Take care.
Bye.